Okay, welcome to day 2 of our CCRN exam review. And today we're going to be talking about hematology and all the common anticoagulants you'll see in the ICU, as well as their coagulopathies, so heparin-induced thrombocytopenia and DIC, or disseminated intravascular coagulation. Those are going to be the main few questions that you'll see on the exam, is one of those clotting disorders and probably a question about one of the anticoagulants. And then we'll go into hemodynamics. You'll see a lot of this in a cardiovascular, uh, kind of combined in with cardiovascular questions on the exam. And there I'm going to talk a lot about preload, afterload, and hemodynamic parameters. And I'm going to do that very slowly so we can really understand and build on one thing at a time. So by the time you're done, you're answering these high level questions and feeling confident about it. If you have a question, it's probably on the next slide, just from the way I've broken things up. And yeah, let's get started. So, hematology, you're only going to see about 3 questions. It's a very small section, but the things that you see in hematology are things that you'll see in the ICU. And we'll start with just what are the most common anticoagulants, and those being your heparins, or you have 2 types of heparins, your warfarin or Coumadin, and your Eliquis or Xarelto, those longer term medications that people are on at home. And something I always kind of teach my patients is that these bloods don't, or these drugs really don't thin your blood. They don't change your viscosity or how thick your blood is, but they instead slow down or hinder the clotting cascade. That way you don't get a clot. Okay. Um, but even though the drugs are commonly referred to as blood thinners. So let's start with heparin, and we'll go through kind of how it works and what the body does in response to heparin, because it doesn't like the fact that it's being anticoagulated. So you have 2 types of heparin. You have the unfractionated heparin, which is what you give in the IV form. You also give it subcutaneously a few times a day to your patients. And this type of molecule binds with antithrombin. So antithrombin is an endogenous anticoagulant, so it kind of works already in your body. And heparin binds to it and helps it work better. It kind of gives it this second arm, if you will, this long second arm to grab onto things more efficiently. One of those being 10A, factor 10A, which is a part of the clotting cascade we'll see in a second, and thrombin. So it's going to grab onto these and deactivate them so you don't start the clotting cascade. And because of this, because it has a longer arm and it can grab onto more things, it's going to have a shorter duration of action. It's going to be used up more frequently. That's why we have to give it 3 times a day. And we get heparin. You don't have to know this for the test, but just a fun fact to know is we get heparin from porcine liver and bovine liver. So that's pigs and cows. So when you have a shortage of heparin in the hospital, it's often a manufacturing issue. Either something happened at the factory, or there's an outbreak of swine flu or an outbreak of mad cow disease. So just think about that when you get the shortage, is that, oh, something must bad be going on somewhere, because um, heparin is gained from the liver. That's why it's called heper, because it's Greek for liver. Anyway, the low molecular weight heparin, or your Lovenox, it has a lower molecular weight because it's been fractionized. Okay, unfractionated heparin is not turned into a fraction, whereas low molecular weight has been turned into a fraction. It's a fraction of what heparin used to be. So it can be more costly because it takes a laboratory to cut this, but it is a more reliable drug, and it lasts longer because it can only grab onto this 10A molecule. It has a much lower affinity for thrombin because it can't reach around and bind to it. So that's just something to consider when you give these drugs. You'll see unfractionated heparin you can give, you have to give 3 times a day versus your Lovenox is once a day. So how do we reverse these drugs? Well, they're negatively charged ions, heparin. So we can give a positively charged ion and bind to it to deactivate it. That's what protamine sulfate is a cation that we can give, and it goes and it links up with heparin and deactivates it to make a stable ion pair. It neutralizes it. So that's how the antidote works. Now, when we look at how thrombin works, antithrombin, this is the thing we bind to make it more effective. Antithrombin will bind with a clotting factor, either 10A or 2A, or thrombin, and inactivate it. It'll fill it, and this prevents it from starting a clot. Now, here you can see the heparin, you can bind to it, and it just helps with the inactivation. Same thing here, the low molecular weight heparin, it can help bind with 10A. Now, the body sees this antithrombin differently than it does antithrombin. You can see this one's kind of a smoother shape. This one's more clear cut. That's just a visual to say that the immune system recognizes this change, this addition of heparin, and it's going to create these antibodies because it doesn't know necessarily that it's helping the body. It can't tell that. So these heparin antibodies are going to bind with heparin, and then the tail is going to catch on to platelets and start these little small microparticles, clots. So even if who necessarily doesn't have a need for heparin or for anticoagulation, if I were given heparin right now, my body would start to make these antibodies. And it will do that for up to a month after I've received that dose of heparin. So after that heparin has left my body, if I've gotten just 1 dose of heparin, and after however long the half-life of heparin is, it's gone, my body will still produce antibodies. Now, what that means is my next hospitalization, if I still have those antibodies, I may be at more risk for a clot forming in the form of HIT, this heparin-induced thrombocytopenia. I may be more at risk of that if I'm started on heparin again. So that's something to think about, is looking at your lab values, seeing if you're going to develop HIT, and I'll go over those in a minute. But also, was my patient recently admitted, and were they on heparin? And the likely answer is yes, because we put a lot of our patients on subcutaneous heparin to avoid clots because of inactivity. So what are your standard labs and HIT response? Well, there's a lot on this slide, but I want you to focus on the image in the center first. This idea of a clotting cascade, this coagulation cascade, and how we in the laboratory look at that. Okay, so on the left side is your intrinsic pathway. So this is everything in your vascular endothelium. So if you have an injury, like if you get poked with a needle, you can have your blood drawn, this pathway is going to be activated to close that hole after the needle's removed. And we can measure that pathway with a PTT. Okay, now let's say you have a big trauma, something that's more serious. you have your extrinsic pathway, which is going to be activated by tissue factor and factor 7, and we measure that with a PT, or a prothrombin time. So that's the difference of those two labs. You'll see I've always had the question of what's the difference between a PTT and PT. Well, you're measuring two different pathways here. And so when we send down a blue top tube, there's a citrate in this tube. And as if you've ever taken care of a CRT patient who's been on a citrate infusion or a citrate fluid, or citrate has been added to the dialysate, then you know the importance of replacing calcium. And the reason why we replace calcium in CRT patients is because citrate in these blue tubes binds with calcium, and calcium is important for clotting. So if we bind that calcium, then the body or the blood is less likely to clot. So we send that tube down, and lab will add calcium back into the blood at the appropriate amount to then reverse the clotting. So they add calcium to then start the clotting process, and they time that. That's why it's important to get those blue tubes down and allow them to get it the most accurate time on that clotting cascade. So big things to look out for heparin-induced thrombocytopenia is you want to watch your platelet count, right? We know that these antibodies are going to start the clotting cascade and use up a lot of these platelets as a normal response to heparin. So we want to watch those platelets and see, is our patient particularly sensitive to this heparin? Are they developing HIT? And they might have a drop in platelet count, but it might be over a long period of time. So it might not necessarily indicate HIT. But if you see a large drop in a short amount of time, if you see petechiae, which is clotting of the capillaries where they burst, then that's going to kind of trigger your response to say, oh, something might be going on with this heparin infusion that we might need to change. So you would stop the infusion. Sometimes your hospital will draw an ELISA test, which can check for this HIT response. And then you'll start your patient on a direct thrombin inhibitor. So you'll kind of pass this cascade, these two pathways, and go right to thrombin just to keep your patient anticoagulated. And then in the meantime, we'll start the transition to warfarin, because warfarin, you'll see in a few slides, it takes a long time for it to reach therapeutic levels. So a normal PTT, and this is dependent on what kind of therapy you're going for, but a normal PTT or clotting time is between 25 and 35 seconds. So if you're on a low or high intensity therapy, this range might change, because the goal with heparin is to have a longer clotting time. Right? You want to avoid these fast clotting times, these low second clotting times. And that's what's so great about what has been so great about technology is we can receive these lab values and then have a goal-directed therapy to say, below this PTT value, adjust your heparin drip accordingly. So we'll be watching the clotting time, just as we normally do with heparin, to make sure we're not over-anticoagulating. And we'll be watching our platelet count. We want this to stay above 150,000. But just because the value is high, my platelet count might be on the higher end. And just because mine starts off at 350,000 and jumps down to 200,000 just because I'm within a therapeutic range doesn't mean I'm not having a hit response. If I've dropped 150,000 platelets in a short amount of time, even though I'm therapeutic, that tells me that my body is definitely responding to this heparin. So the goal with heparin is always a minimal change in platelet count and to optimize the PTT for as long as we can until the patient doesn't need to be anticoagulated anymore by heparin. And here's a little graph. They're not going to ask you this kind of stuff on the exam, but it's good to kind of understand with your own patients what this time frame and drop means as far as risk for hit. So the higher you are on this category, on these categories, put you at a more risk for hit. So you have things like how much of a drop, how quick was the drop, and then have you proven that the patient is clotting, and is there any other reason for clotting? If there's no other reason for clotting, then it's definitely a consideration that it's caused by the heparin. Okay, that was great. We got through the heparin and the heparin-induced coagulopathy. And so now we're going to move on to warfarin or Coumadin. We get a lot of these patients who've had a history of clotting formation or at risk for clotting formation on these drugs because warfarin works heavily on the intrinsic pathway to prevent clotting. And now the normal clotting factors are activated by vitamin K. It's a necessary vitamin that is required to activate many of these clotting factors. So you can see 9, 10, prothrombin 2, or 3. They're all necessary. They're all activated by a necessary vitamin K. And so what warfarin does is it prevents the enzyme that recycles vitamin K. So let's say I have 100 vitamin K molecules and I use 75 of them. Well, my body might not necessarily be taking in vitamin K right now, so it needs an enzyme to recycle that and get it back. So then it recycles it, and I'm back up to 85 or something. Well, warfarin's going to come in and it's going to block that enzyme. So I go from 100 to 75, and I don't recycle that, so I go down another 25 to 50. And you can see that that's where you slow the clotting cascade down. That's how you kind of prevent clotting with warfarin, is you slowly siphon the amount of vitamin K that's available to go to the next step. Now, warfarin takes several days to be therapeutic. That's why it's bridged. So that's why you'll be on a different anticoagulant when you start warfarin. And we measure warfarin, how effective it is, because not all laboratories are the same. If I go to a laboratory in one state and their machine may be calibrated a little bit differently than another state. So what the world has done is they've created this internationally recognized ratio that you can plug in. The laboratory will plug in its settings and it will spit out an appropriate ratio to really tell you how effective clotting is when on one of these medications. So a normal INR, a normal ratio, if you were to just draw my blood and plug it into that algorithm, would be between 0.8 and 1.2. Okay? And the goal, the therapeutic goal, if on warfarin, would be between 2 and 3. So that's why patients have to come in regularly and get their labs checked with warfarin. It's a more long-term drug. We want to make sure that they're still being appropriately anticoagulated once they leave the hospital. And so they'll come get this drawn. So how do we reverse warfarin if a patient comes in and they're, traumatically bleeding? Well, we're going to give more vitamin K. And now that seems counterintuitive because we're blocking all the recycling of vitamin K. So because we can't recycle it, we just have to supplement and give vitamin K so the body can actually clot. Okay, warfarin doesn't stop vitamin K, but it stops it from being reused. Another thing we can do is give Kcentra. Kcentra is essentially just a concentrated bundle of all these different factors that promote clotting. Another thing we can do is give fresh frozen plasma, which contains all the clotting factors. Okay, we can get use of all these clotting factors, and if the patient's low on platelets, we can also give them platelets. There's actually a really interesting website. The American Heart Association has this reversal guidelines, so you can go in and you can see all of the reversal agents and how to use them, how much to use them, how they work. You just have to type in this into your Google and pull it up. But it's a great PDF that I think a lot of units should have just as reference. All right, so this next topic, it's a complicated topic, so I want to make it light and give you something to reference or to help you remember it, and that's disseminated intravascular coagulation, or DIC. You probably have heard about this, maybe not have seen it, but it's a lot like the movie Chicken Run. This movie is a claymation. It's a funny movie about these chickens trying to escape from the farm, and so the climax of the movie is them getting out and escaping, but the build-up is the planning, and that's how I want you to think about DIC is as this big sense of planning before you really start to see something big change. So when we look at DIC, something has caused an initial injury. So in that movie, something happened to where the chickens were like, we got to get out of here. And so an initial injury happens, and that causes some cells to release tissue factor, which is like a signaling molecule. And this tissue factor is going to bind with some clotting factors, and it's going to start the coagulation pathway. Okay, and all of this is going to cause a lot of fibrin to make a mesh. So you've got an injury, which causes a signaling molecule to make a mesh net. And that's going to catch your platelets, it's going to catch your red blood cells to make a clot. And the body tries to respond to this by releasing a ton of anticoagulant. And what that does is it breaks down a lot of these clots, but you end up using all of your resources up. So your body's trying to clot, your body's also trying to fight the clot, and what ends up happening is you use up all your clotting resources from this internal battle of back and forth, all the way up to the point of where, like in that movie, everything's released, all the chickens break free, and you have no more nets, no more clotting ability, and you start to bleed out. And that's why you see increased bleeding time with your PTT, PT, INR. And so when we look at the labs, you're going to see that the fibrinogen, the stuff that's required to help make a clot, you can see a little picture on the right here, is going to be low because we're going to have used it all up. So initially, this disease is a clotting disorder to where everything starts clotting incorrectly from an initial injury. So your fibrinogen is low. You might see a question like this on the test. It's going to give you some results, and you've got to determine, is this DIC or is this something else? Your platelets and your hematocrit are low because your blood and platelets are being collected by these nets. And then eventually, all of this is used up and your body can no longer clot. So your bleeding times are much longer because you've used all your resources. Right here are the normal values that you'll probably have to remember for the test. And here, anything higher than that is associated with DIC. Now, another couple labs they'll draw to test for DIC is fibrin split products and your D-dimer. Now, once you've made all these clots, your body's going to start breaking them down like we talked about. And they're going to be broken down to essentially garbage, fibrin split products and D-dimers. And so you can draw that in a lab tube and see how high these values are. And they should be very low, right here, below 10, below 0.5. So anything above that tells you that the body's breaking down a lot more clots than it should be. So you need to identify what is potentially causing, what is the trigger to this clotting disease? Why are we using so many resources to clot? And then you want to administer vitamin K. Remember we talked about that. Vitamin K helps with the clotting cascade. So even though we're using up all of our clotting factors, we want to stop the body from bleeding out. That's the most important thing. Is even though we've used up all our resources, we want to continue using those resources in order to stop the bleeding. We don't want to lose blood. That's the key. Is we don't want to lose blood because it's easier to replace those clotting factors. We can give platelets, we can give FFP, we can give cryo. These are all things we can give. We want to stabilize the system. If we give blood, we're really not solving any issue, right? We want to replace the clotting factors. We want to replace the vitamin K to make the process continue to work. And we want to fix the initial issue that's causing those clotting factors to be used up. And if we need to, we can start a low-dose heparin to make sure that we're not clotting anymore, to stop that clotting cascade. We want all the right levels of resources available while we try to figure out what the inciting factor is. All right, so we'll do some clinical questions and some rationale before we move on to hemodynamics. So we have a 54-year-old woman who is admitted with a DVT and PE. She received a heparin bolus and a continuous drip. The next day, we expect HIT to be an issue, and the drip was stopped. What of the following would indicate that lady had developed HIT? We see surface bleeding from IV sites and an elevated PTT. We see a loss of pulses and an INR of 5. We see petechiae and a low platelet count, or we see a change in her level of consciousness. Something that would incite you to think HIT. Okay. So we want to be thinking about, in HIT, we want to be thinking about all of our platelets being used up because of that. Because of those heparin antibodies. Those antibodies are going to bind with heparin and they're going to bind to platelets to form a clot because it doesn't recognize what's going on. So bleeding from IV sites and a prolonged PTT was what we kind of just talked about with DIC. You have longer bleeding times later in DIC because you've used up all your clotting factors. And any kind of change in level of consciousness may be more secondary to a stroke. So if somebody, if we expected her to come in with a CVA instead, that had then gone from a ischemic stroke to a hemorrhagic stroke, that would be a reason why we would pick that last answer. So petechiae and a low platelet count would really encourage you to pick HIT over anything else. 2 days later, that same patient is scheduled for insertion of an IVC filter to help protect her lungs from future PEs. But the pre-op lab shows a platelet count of 20,000. So what would be the most appropriate with a platelet of 20,000 and a scheduled surgery? Okay. So this could be tricky because when you see something like this, you want to try to do something to help, right? But one of the best things to start, places to start, is to let that surgeon know that the patient it probably isn't safe for this patient to go to the OR, right? With a platelet count of 20,000 and a very high risk for a surgery like this, when you're poking into large vessels to place a filter, you may not be able to gain hemostasis with a low platelet count like that. And you would want to continue argatroban, right? We replace heparin with argatroban until we can bridge over to a different anticoagulant like warfarin. And so it's most likely that this just needs to be rescheduled until we can stabilize the patient more. All right, this is a different patient. A patient with septic shock is thought to be developing DIC, so disseminated intravascular coagulation. Which of the following lab results would be most indicative for DIC? So remember, there's an early phase of DIC and a late phase of DIC. What lab value would indicate that? Okay. You could feel free to pause this at any time to read over these answers and think about it. You got a minute and a half on the exam per question, so there's no rush. You're allowed to pause and think. Well, the key with DIC is that what's the end product of breaking down these clots? That's going to be really key in telling us, are we breaking down a normal amount of blood clots in the body? And if not, then these values should be high. If we're breaking down too many clots, then our garbage, the fibrin split products and the D-dimer, should be elevated. Okay, any kind of ELISA test that's with HIT, you may expect a lower platelet count with HIT. And these high bleeding times could be something that you would see with HIT as well. Okay, and that was hematology. And now we'll move into hemodynamics. And I merged this with cardiovascular as far as how many questions you'll see, because they'll probably give you a cardiovascular question and have you base the answer on some hemodynamic values that you'd likely see as well. So knowing this will help you answer cardiovascular questions as well as the hemodynamic questions. All right, so now we're going to look at the foundations of hemodynamics, and I really want to go through all of this just one little piece at a time. I want to cover heart rate and stroke volume, and I want to just add a little bit to each one of those before we jump into anything different. Because a lot of us don't work in the cardiovascular ICU. We don't see these values that often, and they aren't always talked about in our orientation. So we're going to take it slow. That way we can really have the best chance to understand these questions at the end of the lecture. So we all know what a normal heart rate is. That's how many times your heart beats every minute. And something that we don't really look at is how much blood is pumped out with every beat. And that should be between 50 and 100. Now that can vary based on the person's size, right? My heartbeat may pump out less than a bodybuilder, Olympic bodybuilder. But you multiply those values. How many times does your heart beat in a minute? And how much volume on average does it pump out with each of those beats? And you do that calculation and you get your cardiac output. How much your heart can output every minute. And that should be between 4 or 8. These numbers you'll just have to remember just for the exam, but you'll be seeing them enough to have them just kind of be integrated into your memory. So heart rate times the amount of blood pumped with each beat equals the amount of blood that leaves your heart every minute. Okay, so how do we measure that? Well, we could use a stress test. We can use a bedside echo where they put a camera and they can see exactly and they can measure how much volume is in your left ventricle. Right? That's not a test I can really do as a nurse to see how much your stroke volume is. And what's fascinating about the left ventricle is it doesn't pump out every milliliter of blood it gets. So my heart, for example, might hold about 130 milliliters in that left ventricle. But it is only going to pump out between 50 and 100, depending on, how stressed I am or if I'm sleeping, how much my body really needs. And so what we get is the leftover calculates our ejection fraction. What fraction of our blood in our left ventricle is released in each beat. And so when we talk about this patient, they got an ejection fraction of 55. Oh, that's good. They don't really have heart failure. What we're saying is for every beat, that patient is pumping out 50 to 65% of their volume in their left ventricle. And you get that by checking with an echo. Okay, so anything low might tell you that the heart's not pumping well, and anything too high means it's pumping too hard. So that when you see those values, that's what you think of. Is it low, then the heart's not working efficiently. If it's working high, if it's high, it's too efficient. So when you look at these values, I want you to think, anytime I have a fast or low heart rate and my stroke volume isn't compensating, then my cardiac output is going to be lower. Right? If my heart is beating very fast, then it might cause my cardiac output to go down because I'm not allowing that as much volume to fill this chamber. And whenever your cardiac output is low, usually you have hypotension. Right? This is how much blood is released. If that's lower, then you have less blood, and therefore you have hypotension. And here's a little fact for you. The most your heart rate can be before you start losing your cardiac output, before you start losing your hypotension, is between 130 and 170. So if you have a very compromised patient who has a lot of comorbidities and they have a heart rate in the 130s or 140s, I want you to think that, hey, they're probably not pumping out that efficient of a volume every minute. That might be why their blood pressure is low. So I'm going to try to fix that heart rate or fix the issue that's causing that heart rate to be high. And we know that if a patient has a low blood volume, that their heart rate can go up. If they're dehydrated, their heart rate can go up. That's what that means. So just think about that in a very, very healthy person, even a high heart rate like this may mean that their heart really isn't being as efficient as possible. So, how do we get more specific numbers for different individuals? If you have two patients and they both are hooked up to a monitor that tells you these values, one is 100 kilograms heavier than the other, how do you get a more accurate number to represent what their cardiac output should be? And you can do that by dividing their body surface area. Okay, they're not going to ask you this calculation on the test, but they're going to have two different values, and you need to know what this means. So cardiac output is just a blanket term, and cardiac index is a more accurate patient-specific value. Okay, so they're not going to have you calculate that, but you're going to need to know that there's a difference in the number. So cardiac output is 4 to 8. Cardiac index is about half of that. So if you can remember cardiac output, you can remember cardiac index by just saying it's about half. Okay, this is way more accurate. And they have the same thing for stroke volume, right? Because everybody's heart is a little bit different in size. So you do the same thing, body surface area divided by stroke volume. You don't have to know that calculation for the test, but you have to know that it's about half of the stroke volume. So 50 to 100, 25 to 45. That's close enough, right? About half. And so they may give you a stroke index, or they might give you a cardiac index, and they might say, is this normal? And all you have to know is this the range of values. And if you can't remember that, all you have to do is remember the stroke volume. And what is it? It's half of that. So I went to a national nursing conference, and they had this amazing technology where you can put a blood pressure cuff on your finger, and it'll stay half inflated, and it will measure your average pressure in the artery in your finger. And what that'll tell you is, in combination with your heart rate, it'll tell you your cardiac output. So you can see mine here is about 5.7. That's within range. It's 4 to 8. That's good. And then you can see my stroke volume here is 68. That's good. That's within range. So you could take these numbers, you could divide them by my body surface area here, 1.8, and you could get values. So my cardiac index here is 3.3. That's good. My stroke volume divided by my body surface area gets me my stroke index. That's 42. That's good. And then this is just estimated. I just said, hey, maybe I have 115 because I'm a lighter person. Maybe my heart holds 115, a little less than average. And so I took my stroke volume, divided that by how much my left ventricle can hold, and I get my estimated ejection fraction. Right? The only way you can know how much volume your heart can hold is by getting an echo. So this is just some fun stuff, some fun technology that they're coming up with, non-invasive ways to measure these values to see if our patients have good output, good cardiac output. Okay, so we'll move on to the next little step here. Remember, this is all just one little thing at a time. So what we next want to see is how much volume is being returned to the heart. And that's venous return, right? So all that stuff is dependent on your volume, how much blood volume you have, how tense your skeletal muscles are, right? If I'm all tense and resisting, then my blood's going to get back a lot higher pressure. And then how clamped down is my peripheral circulation? If I have a lot of peripheral vasoconstriction, that's going to push my blood back a lot quicker. So when we look at how much volume we have at the end of diastole, the end of relaxation. That's all dependent on how much volume we have and how fast our heart is beating. So how much volume do we have at the end of relaxation? And that is basically preload, right? That's how much volume is about to go into your left ventricle and be pumped to the body. Does that make sense? So all the blood that's coming back to the heart, and how fast that's happening, is how much blood is about to go in to the left ventricle to be pumped out again. Okay? So if that volume is low, then what we're going to have is we're going to have a lower stroke volume. We're going to have a lower amount of blood being released because we have less blood coming in. So we can do something to try to fix that. And if that number is high, it means we might have heart failure. Very rarely is this number high and you don't have heart failure. That means that the heart isn't pumping effectively, so we have a ton of blood about to be pumped out. But it can't. So if it's low, you're not getting enough volume back, and if it's high, your heart's not able to pump it out. And so what are these numbers, right? We talk about these preload numbers. What are these numbers? Well, these numbers are your CVP. Now, at the hospital I work at, we actually don't really look at this number because there's a lot of controversy and evidence about, is this effective? And I had a great nurse tell me once, it's not that it isn't effective, but it's how you look at it and how you treat it is how effective looking at this number is. So a lot of people think CVP, central venous pressure, that's the pressure right before your right ventricle. A lot of people think, oh, that's volume status. That's how dehydrated my patient is. Right? If it's a low pressure, my patient's dehydrated, give them volume. That's not necessarily what that means. If it's a high number, that means something's backed up. So when we think about central venous pressure, this pressure right before the right ventricle, we think about that's the amount of pressure that the right ventricle is being, that we're pushing against the right ventricle. So it's like a camera. When you take a picture, you're looking at something. So when we place this, you'll see in the next picture, when we place like a central line, the tip of it is the camera. And it's positioned right before the right atrium. So it's looking into the right atrium. And that right atrium tells us the pressure that it's going against the right ventricle. Okay, and that number needs to be between 2 and 6. Okay, you could write that down, and then later we're going to look at how to change that number. But right now you just write it down and keep track of it. Okay, so this is all preload. This is all volume going somewhere, not necessarily. This is all volume going into the heart, not being pumped out of the heart. So if we can do that on the right side, we can also do that on the left side. We can stick a camera in there, or a catheter. We could stick a catheter in there, which is essentially a camera, and we can look at what is the pressure of the left ventricle. And so we stick a pulmonary artery catheter all the way into the heart. We thread it down through the right ventricle, and we kind of stick it up here in the pulmonary artery. And then we block off one of the pulmonary arteries. And then we take the picture. We look. What is the pressure looking forward? How high is that pressure? Okay. If it's low, something's wrong. If it's high, there's something wrong. So it should be between 8 and 12, right? As you move from the right side of the heart to the left side of the heart, pressure is going to increase, right? Slowly, it's going to get higher. So when you look at these numbers, If you forget the numbers for some reason, just always remember the lowest numbers are going to be on the right side, and the higher numbers are going to be on the left side. Okay, I'm going to show you a picture. Now, you don't have to worry about the bottom half. I just want you to look at this red line up here with me. This is our catheter. This is our camera. So when we put in a pulmonary catheter, which we don't really do in the medical ICU and not so much in the surgical ICU, but we get to see all these numbers, these fascinating numbers of what our pressure is looking like ahead of the camera. So you see we put in this catheter. This is our CVP, central venous pressure, which is essentially the pressure in the right atrium. And we can see, oh, it's about 2 to 6. We put the camera in there. Yep, this is about 2 to 6 millimeters of mercury of pressure, right? Very low pressure because all this blood is just dumping in, just kind of pouring into the right atrium. It's not really being pushed in there. Okay, so we move this catheter a little bit further, and now we're looking at the right ventricle. Okay, and that should be 20 to 30 over 5. Again, you don't really have to memorize these numbers right now. Just write them down. Because I'm gonna go through them later, and we'll do a review here in a second. And then you can stick this even further, and you're just looking here at the pulmonary artery. How tight is this pulmonary artery? How much pressure is in this pulmonary artery? Right? If you were to have ARDS or pulmonary embolism, this would be very high. Right? You could stick a PA catheter in your camera, look at your pulmonary artery if you suspect some sort of occlusion or disease process, and that could confirm, these numbers could confirm that if it was high. And then, like I said, you could stick this camera all the way up, inflate the balloon, and the blood's going to push it and wedge it into one of these arteries. And you're going to be able to see a pulmonary artery occlusion pressure. It's the same thing. PAOP and PCWP. It's the same thing. It's just wedging into that artery. And we said that was between 8 and 12. Yeah, this is just variance. People say different things, but it's, for as far as the testing purposes, just think about 8 to 12 of what this pressure is looking at. And this is looking at this left atrium. So it's coming out, it's looking at everything ahead of it, which is the left atrium. And if you see this waveform, this is just the picture I found. That was a very good picture, but the bottom, they're not going to show you waveforms like this. Okay, so let's just review. We'll go through things slowly and review. Okay, so we know what a normal heart rate is. We know that for every beat in this heart rate, we should expect between 50 and 100 milliliters of blood to be pumped out. And that should equal 4 to 8 liters of blood per minute that's leaving the heart. That's awesome. Okay. And then more specific numbers. We can get more specific for our patient over here by dividing it by body surface area. And it's about half. So half of 50 and 100 is 25 and 45. Half of 4 and 8 is about 2.5 and 4. These are the numbers that are going to be on the test. Any of these numbers could be on the test. Okay. And then we're thinking about preload. How much blood and what's the pressure of that blood in the right atrium, right atrial pressure. Okay. 2 to 6. That blood, what its pressure in the right atrium is between 2 and 6. And you can measure that, and it's usually called a CVP. So when you can get that with a central line, you can get that with a pulmonary artery catheter, and it's that first part of the heart, how much pressure is in there. And then you can stick that, if you want to look at the left side of the heart, you can stick that all the way down and into their lung, the artery in their lung, to look at the left side of their atrium, the left atrial pressure, 8 to 12, right? Higher than the right side. So that's great. What devices and lines do we measure these with? Heart rate, EKG, or just your 5 lead. You can get your heart rate. Stroke volume, you need a catheter in the artery. So you need an art line, and you need to hook it up to a flow track. That's the device we use at our hospital. Another type of machine is called an Argos monitor. You can do that. But you need to be able to see an arterial waveform in order to get that for the computer to calculate that volume. Right? Same thing for the cardiac output. If you have a stroke volume and you have a heart rate, then the computer can calculate the cardiac output. And because it's a computer, you can put in how heavy the patient is and how tall, and you can get the body surface area. So cool. All this stuff requires on the top is 5 lead and an arterial line. That's awesome. Down here to measure preload, you need a camera looking at the back side of the heart. So you need either a central line or you need a PA catheter. A catheter that can go all the way down and into the lung. So that was some of the easy part. We just reviewed that. We built off of it. We did very well. And so these little questions are just to kind of smooth out those edges, make it sure we're learning what we're required to learn. So what would a normal left ventricular end diastolic pressure be? What would at the end of diastole, what would we expect our left ventricle to be? How much pressure would we expect to be there? Well, we'd expect it to be similar to the left atrial pressure. So around here, 8 to 12. So we fish this catheter up there, we wedge the pressure, we take a picture to get our blood pressure in that area, and we would see what our pressure is right before systole. Okay. And what would a normal right ventricle preload pressure be? It'd be the same as the right atrial pressure, right? A little bit higher than a right atrial pressure. Because all that blood that we're putting into that right ventricle is the same blood that was just in the right atrium. So really there should be no difference. All right. So if we have a high a high heart rate, 150, what would that likely do to our cardiac output? Right? And a healthy person, that might not change it. You know, if you're exercising and your body can compensate for it, it might not change it. But if that goes up and you don't have the volume to multiply by the heart rate, you might get a lower cardiac output because you're not giving the heart as much time to fill that ventricle. So the faster you beat, the less time you have to get that stroke volume number up to the 50 to 100 milliliters it needs. Okay. So how would the heart rate, the stroke volume, and the cardiac output change after major blood loss from a trauma? You get a patient, you got attacked by a dog or something, or you got a patient that broke their leg and they cut one of their veins in their leg. Well, you'd have a lot lower stroke volume, right? You'd have a lot less volume in your blood. Hemorrhagic shock, you have a lot less volume, so your heart's going to be faster to try to make up for that. Right? Your heart wants to maintain the cardiac output. That's the goal. So if you have a lower stroke volume, your heart's going to be faster to try to get to that normal cardiac output. And you might be able to do it for a while until your heart tires out or you lose enough blood. And then you're going to pass out, right? If you don't have enough blood, cardiac output going to your head, you're going to pass out. So what would likely change first on your camera, on your flow track? Would your stroke volume change or your cardiac output change? Right? What would probably change first? Well, it'd probably be your stroke volume, right? If you become a little bit more dehydrated or your patient's got a chest tube that may be bleeding and your blood volume starts to go down, you're going to see that stroke volume kind of trend downwards. And if your heart can't keep up with it, then your cardiac output's also going to start trending downwards after. So that's great. That's great technology because we can see, oh, hey, my stroke volume's gone down the past hour. I've been checking it every 15 minutes because this patient's pretty sick, and it went from 55 to 50, and now it's 45. I might expect in the next 15 minutes my cardiac output to go down. So that's great technology to be able to see that and see that first change in stroke volume and then cardiac output because it allows you to respond in real time. So something I always recommend, this is more clinical than going to be on the exam, but if you have the opportunity to set one of these flow tracks up, take it. If you can understand the numbers and what they mean for your patient, then take that opportunity because a lot of the apprehension of starting these therapies is, well, we don't know how to use it, right? We were taught, but we were taught by somebody who was maybe taught by somebody who kind of knew it. At least that's the case I've seen. And so now knowing a little bit about stroke volume and cardiac output, when you see these, you'll better be able to understand the numbers and say, hey, to the doctor, hey, I noticed this change. Here are my numbers. What do you think about that? And they're going to be able to have a conversation with you earlier rather than asking you 4 hours later, hey, how's their flow track doing? You're going to be able to see the problem before they will. That's the key. Okay, so let's add another little element. We'll just keep going like this until we cover it all. We're going to add another little element, and that element is contractility, how hard your heart pumps. And what's that going to determine? It's going to determine how much volume leaves that ventricle, how much of that stroke volume. Okay. If you have a very strong heart, if you're young and you don't have much disease, then great. It's going to beat very, very well. And now that's not how fast it beats, it's how strong it beats. So if you have heart failure and you can only pump out, if your heart works at 50% of what it should be, you're going to pump out a lot less blood. That's why we look at ejection fraction, right? The heart doesn't pump as strong as it needs to be, so it doesn't kick out as much blood. So that's contractility, right? These things are starting to link up to stroke volume, right? Your amount of blood that enters your heart, that's going to determine stroke volume. How hard your heart beats, that's going to determine stroke volume. You can't really measure contractility. You have to kind of look at other things. You can't really tell how hard the heart is pumping. So look at the difference in these. This is your preload is based on time. How much time is allowed for that blood to go into the ventricle. And then how much volume you have. Contractility is how healthy is your heart. How well can it squeeze. And then the last thing is how much volume is at the end. How much is already out there in the body that you're pushing against. Right? Are we throwing water at a wall and is it just bouncing back? Is it making us have to push a lot harder to get that water out? And that's afterload. That's end systolic volume. This was end diastolic volume, how much we have at the end of relaxation that's about to be squeezed out. Then we squeeze it out, and then this is how much we're pushing against. So this is all based on how volume overloaded your patient is, how tightly your vascular bed is squeezing, right? Do we have a lot of pressors that we're giving our patient that's causing everything to squeeze? Or is your patient hypovolemic and have high vascular permeability from sepsis? Right? So you have three factors that determine how much blood is leaving the heart. And that is multiplied by your heart rate to get your cardiac output. So all these factors affect how much blood can leave for each beat. You multiply that by how many times it's beating per minute, and then you get your cardiac output, which is in the end is the most important thing, one of the most important things. So more numbers. We're looking at afterload. How much resistance, we'll start at the right, how much resistance is on the right ventricle? How much is pushing against that right ventricle right before it beats? And usually that should be between 50 and 250. Okay, and this value is speed. We have to measure this by speed and temperature. So with the pulmonary artery catheter, that's the only way to measure this. Is you'll measure the change in temperature from the beginning of the catheter to a different point in the catheter. Okay, now that you don't need to know. You don't need to know that, but the computer is going to be able to determine that change, and it's going to give you this resistance. Okay. And then let's look at the left side of the heart. Systemic, right? This is systemic. This is pulmonary because the right ventricle pushes against the pulmonary vasculature. The left ventricle pushes against everything, the systemic vascular. And so look how much higher this is. The highest you should expect to see in the pulmonary vasculature should only be 250. There shouldn't be too much pressure, but when you're pushing against the whole body, it could be up 10 times as much, 1200. So let's say somebody's on a lot of pressors, then you would think that this would be higher, right? The systemic vascular resistance. We're giving drugs to make this number higher. Or if they're septic and they just came in septic and everything's blown out and they have low vascular or have a high vascular permeability, everything's dilated, then you would expect this to be low. Or if a patient has ARDS or some sort of congestive lung disease, then this number should be high, right? There's a high pressure we're pushing against because everything's tighter than it should be. So that's your those are the big three elements that go into stroke volume. We know heart rate, and we know how to calculate cardiac output. So we'll take a step away from blood pressure and all these pressures and numbers, and we'll look at oxygenation. Okay, we're going to look at oxygenation, and this oxygenation is really going to tell us how hard the body is working. It's going to tell us either how hard the body's working, or are we getting enough oxygen in the first place. And so if we look, we all know what SaO2 is. It's the amount of oxygen in the arterial blood, and we always talk about wanting that over 95%, over 92%. And this is very similar to SpO2. So if we take a step back, what should the oxygenation of the blood be very early in the heart? Central venous, right? You think of a CVC, a central venous catheter. That's the blood that is right at the end right before the right atrium. And that blood is very dark, right? That's probably the darkest blood you'll see because it's very low, has a very low oxygenation count. Okay, between 60 and 80% based on what you're doing. You know, if you're sleeping and you don't have many breathing problems, it's probably going to be higher. If you're in a very sickly state or you're exercising, this might be lower. And then as you go a little bit closer to the lung, you start to get mixed venous blood. Some of that oxygen starts to get oxygenated, and we should never see that below 70%. That means we've been using too much. Okay? So what are the big causes for a drop in this blood right before it gets reoxygenated? Right? That's the best way to see how well we're using oxygen is right before it gets oxygenated. So we see that if it's low, what is the cause? It could be that the amount of oxygen we're consuming has increased without it being taken in. So we've been using more oxygen, but we haven't been taking more in. So an example could be, patient has light, shallow breaths, but they've been becoming more and more sick. They've been requiring more and more oxygen to try to fix their problems. So they're not only is their potentially their SpO2 going to go down, but this SvO2 is what will be really accurate. You'll see, a 68%. The body's using a lot more, but it's not, and it could be okay, but the body's not taking it in. Okay. Another problem could be the heart. The heart can't support the tissue demand. The oxygen is there, but the heart's not pumping it out. Okay, so you've got heart failure. Let's say you have heart failure. Or there's a problem with your heart rate, or there's a problem with your stroke volume, how much blood you're pumping out. And all that is going to determine how much oxygen leaves the heart to go to those tissues. So you could be in a totally normal state of oxygen requirement, but if your heart can't get that oxygen out, then this number is going to be low. 2, if you have a low hemoglobin, if you're anemic or you've had blood loss, where is that oxygen binding to? It's not. It's not binding to the hemoglobin, so if your hemoglobin's low, this number, this SvO2 might be low. So what do you do to fix that? You just give blood, or you solve the issue another way. And then if your actual saturation of your arterial oxygen is too low, and there are a lot of things that could cause that. If the saturation is low in the first place, then it's going to come back even lower because you've still used the same amount, but you didn't start with you started with a lower amount. So just think about these things when you see, on the exam, they're going to give you a bunch of these hemodynamic numbers, and you're going to see an SvO2 of below 70%. And that's going to make you think back to this slide. What are the causes of that? Is their heart working well? Are they requiring more and we're just not giving it? Do they need more hemoglobin? Or are we not even giving enough oxygen in the first place? So again, these are just some examples. These are the same 4 causes. So examples of the 4 causes: low cardiac output, right? We talked about that one. A decrease in our oxygen, right? That's obvious. That's this, we didn't get enough oxygen in the first place. Pulmonary artery oxygen, so we're not getting enough oxygen into the lungs in the first place. Shivering, right? All those little tiny muscles that make us shiver is going to use up a lot more oxygen. Same thing with fever, right? We're burning a lot more oxygen to try to fight off whatever the fever is caused by. Seizures, you're using a lot of muscle, a lot of oxygen to pump all those muscles. And then your work of breathing. So if you're working a lot harder to breathe, that means you're using a lot more oxygen up in the first place. But there are also things that could cause your SvO2 to be high. Okay, and these ones are a little different. You kind of have to think of things slowing down. Just because it's low doesn't mean it, or just because it's high doesn't mean that's a good thing. If you're in septic shock and your oxygen simply can't leave the blood vessel to get to the cell because there's so much volume in between the vascular bed and the cell, extracellular volume, then that oxygen is just going to stay in your blood and it's going to come back and you're going to see a high value. Or if you're hypothermic, if you're cold and you're just not using as much energy, everything's slowed down because you're cold, that SvO2 is going to come back high. So you got to warm your patient up, have them utilize their oxygen better. And then if you're paralyzed, if your body can't activate any of those tissues and your body really just is in a quiet state, it's almost like you're sleeping, right? You're going to have a higher SvO2 just because you're not using those parts of your body. So again, you're going to see questions that it'll drop a little SvO2 question or a little SvO2 value in there, and it'll be easy to skip over if you don't think about what could cause the drop, what could cause the increase. Okay, and they don't have to be that complicated. It could just be you thinking, would I be using more oxygen in this state? Yes, okay, that makes sense why their SvO2 is low. Let's fix that. Let's try to fix that so they use their oxygen more efficiently. So let's go over it again. This is the same stuff as we just talked about, and I just added afterload and oxygenation. Okay, so we know what the normal heart rate is. We know if we multiply our heart rate for every time, or for how much volume is released every time that heart beats, then we'll get our cardiac output, how much blood is released from the heart every minute. And if we need to, we can get more specific values for our patients if we think that they don't fall within that parameter for regular, or average. If they're lighter or if they're heavier, either one, you can get a more specific number with stroke index and cardiac index. And then we can check how much preload we have, how much volume is about to go into the right ventricle with a CVP. You may also see it on the exam as right atrial pressure. Instead of CVP, it might say the right atrial pressure is 2 to 6. And the same with the left atrial pressure. Now this, it'll probably say PaOP or PCWP, pulmonary artery occlusion pressure or pulmonary catheter wedge pressure. It's just the same term, two different abbreviations. And we know that should be higher than the CVP, so 8 to 12. And then afterload, how much are we pushing against? Right? Your pulmonary vascular resistance, how much resistance is in your lungs, should be between 50 and 250. And then in your systemic vascular resistance, we should expect that between 800 and 1200. Higher, because the body, there's a lot more vasculature in the entire body than in the lungs. And then finally, your oxygenation values, the central venous, the saturation of your oxygen in your central venous, which is right before your right atrium, should be between 60 and 80. And then your SvO2, how much oxygen saturation right before it enters the lungs should always be above 70. So what that tells you is you're utilizing 30% of the oxygen in your blood. You don't want any more usage than that. And then we all know what a normal oxygenation status should be. It's around above 90. Okay, so we go into different types of shock, and shock is a state of low cardiac output, low blood pressure. And there's lots of different types of shock. So for cardiogenic shock, the big thing is, what is it caused by? What's cardiogenic shock caused by? Why are we seeing these changes? And why is there a low blood pressure? Well, any kind of major arrhythmia, so any kind of very severe tachy or bradycardia, any kind of life-threatening arrhythmia that changes how the heart is beating is going to change that heart rate. It's going to change that stroke volume. It's going to change how much blood is being put out with cardiac output. Okay, any kind of valvular dysfunction, any kind of stenosis that causes less blood to get through, or any kind of regurgitation which causes more blood to back up, is going to mess up that system, is going to mess up how much cardiac output we have. Any kind of myopathy or heart failure or heart attack is going to cause dysfunction in that wall, meaning it's not going to contract as well. So these big 3-4 things are going to cause congestion. So the big thing with cardiogenic shock that I think about when I'm taking these exams and doing questions is I'm thinking about congestion, right? We're not able to get out the volume we need, so it's backing up. Everything else might be working fine. You know, our preload might be fine. Our afterload might be fine. But something's causing us to not be able to release that pressure or to release that blood. So what we're going to see is a low stroke volume, low cardiac output because of that. And because we have a low cardiac output, we have a low blood pressure. Now, we're going to put that catheter in and we're going to check all these values and we're going to see, oh, our right atrial pressure is high. Huh. Something must be happening further down. Let's go further. So we go down to the pulmonary artery pressure. Huh, that's high too. Let's go a little bit further, get a wedge pressure. Oh, that's high as well. So that tells me that it's so backed up. It's all the way back up to the left side of the heart. So they're going to give you a question about cardiogenic shock, and they're going to give you a high right atrial pressure. So it might be like 8. Remember we said that was 2 to 6. It might give you a high pulmonary artery pressure. And that was the number I said to write down, but not to necessarily know. That was like, I think it was like between 20 and 30 over 5. So any kind of high pressure in the lungs. And then that wedge pressure, that pressure that you put the catheter balloon all the way up into the lung, and then you look forward, and that's going to be high. Anything below, above 8 and 12. 8 to 12, anything above 12. So all of these are going to be elevated. And the key to know with these exams is that the questions aren't going to be right on the edge, right? It's not going to give you a right atrial pressure of 7. It's going to give you like a right atrial pressure of 10 or 12. So it's going to be obvious that something's going on. So they're really not going to really try to trick you. But you have to know what's going on to get the question right. So what is that going to look like for the afterload? If the preload isn't good, or if the preload is high because we're congested, how is the body going to compensate? Well, in cardiogenic shock, the vessels are still appropriately working, so they're going to squeeze, right? The systemic vascular resistance is going to make up for the low blood pressure by vasoconstricting everything to the point where our systemic vascular resistance is above 1600. So you'll say patient comes in with a high right atrial pressure of 8 or 10, a high pulmonary artery occlusion pressure of 22, and a high systemic vascular resistance of 1900. What likely shock state are they going to be in? And then that would trigger you to say, oh, okay, everything's backed up. My body's compensating by having a higher systemic vascular resistance, but I still have a low blood pressure, so I know that I don't have much volume. So it's probably cardiogenic shock, right? And because that oxygen isn't leaving with the blood pressure, you have a low SVO2, right? We talked about one of the things of SVO2 being if you don't have the right cardiac output, you don't have the oxygen getting to where it needs to go. And then it's potential that your pulmonary vascular resistance could be normal or high. Just depends on how congested and backed up you are. Okay, let's look at hypovolemic shock. Right? In this case, you have low volume. Excuse me. So you have low volume. So your stroke volume is going to be low, your cardiac output is going to be low, your blood pressure will henceforth be low. But in this case, you don't have a high pressure because you don't have the volume to preload those ventricles. The amount of blood you're pushing into those ventricles is a lot lower. So your pulmonary vascular resistance shouldn't change, but your systemic vascular resistance definitely should, right? Just to keep up with this low blood pressure, your body's going to vasoconstrict. Okay, those kind of match. That makes sense why those two are in opposite directions. All right, you get in a patient in that's very hypovolemic. They're going to be pale. They're going to be hard to stick with a needle to get labs or to put an IV in. And that's because this systemic vascular resistance, is high. And same thing, you don't have enough cardiac output. You don't have oxygen getting to the tissues. So you're going to have lower values here. Okay, so now we're moving on to early septic shock. Now, one of the reasons why they call this hyperdynamic shock is because the body can still respond to an extent to the shock state. So when you think about early septic shock, you got to think about a lot of these blood vessels are increasing in permeability. A lot of this fluid is leaking out. And so you get this very low systemic vascular resistance over here. So you get a low afterload, which is going to lower your blood pressure. Now, you may still have an adequate stroke volume, an adequate compensatory tachycardia, which is why you still get somewhat normal or high cardiac output because your heart is beating a lot faster, but your blood pressure is still low because you have a low afterload. So really, that's one of the reasons why your cardiac is raised, is because your output is raised because it's pushing against very little. Now, as you go into late septic shock, this hyperdynamic state goes away and you end up in a hypodynamic state. So your blood pressure is still low, but now your stroke volume and cardiac output are gone because you've lost a lot of volume. And what is interesting is your systemic vascular resistance rises, not because your vessels are squeezing, but because you have so much extravascular or extracellular space being filled with this fluid. That makes sense, right? Because you have all this fluid leaking out, and as you get further into sepsis, you get so much swelling that it's going to squeeze your vascular bed and cause a rise in resistance without a rise in blood pressure. So what you end up seeing is you could potentially see a higher pulmonary artery occlusion pressure, meaning that you have a higher pressure on your left side of your heart because of congestion, but not because you have adequate blood volume. So sepsis can be tricky because it changes the worse it gets, right? Early in sepsis, you have a high SVO2 because that oxygen is not getting to where it needs to go. So it's returning back to the cell or returning back to the lungs. And then at some point you decompensate so much that you're not even able to obtain the oxygen into your vascular bed in the first place from the lungs. So sepsis is tricky when you start to review hemodynamics. Just take some more time with it, with sepsis, because it changes. So we'll go to ARDS now. Now, ARDS isn't necessarily a volume problem, a problem with volume, but it's a problem of the blood isn't able to reach the left side of the heart. Okay? You might have a normal stroke volume, and you may have a normal cardiac output, but the blood pressure is still going to be low. So what ends up happening here is you get a high pressure in your lungs because you have an inflammatory process in your lungs. So your pulmonary artery pressure, the pressure within your lung, is going to be elevated, which could potentially back up to your right side of the heart. But your left side of your heart is not going to have the blood flow from the right. Because there's so much pressure here, this pulmonary artery pressure, which is measuring the left side of your heart, can either receive adequate blood or not enough. And so what does this do? This results in a potentially lower blood pressure. Not always, but potentially. So definitely you would expect your pulmonary vascular resistance to be high because you have an inflammatory process in your lungs. But your systemic vascular resistance really isn't going to change. So because you're not having as adequate blood flow through your lungs, your SVO2 is going to be low because you're not supplying the oxygen, right? And that's one of the 4 causes of a low SVO2 is not supplying the oxygen. Very similar with pulmonary hypertension, right? Your stroke volume, cardiac output, and blood pressure are going to be okay. But you're going to have such a high pulmonary artery pressure that it's going to cause backing up into your right atrial pressure, your right side of your heart. So you have your high pulmonary vascular resistance, you have high preload because of the disease process. So your SVO2 may be low just because you're not able to adequately get the blood through the lungs at a rate which is normal. So this isn't always a shock state, pulmonary hypertension, but at least it shows you what happens with these values, these preload values. So you may get a question of a patient in pulmonary hypertension on Remodulin, and you start to see the preload pressures of the right side of the heart rise and the SVO2 go down. And that's going to trigger you to think on that question, okay, do I need to contact a provider and maybe do we need to change the rate of the Remodulin or do we need to change therapy? Is their pulmonary hypertension getting worse? What's going on? So these values can tell you a lot about the state that your patient's in and based on the specific disease they're going through. And then tamponade, cardiac tamponade, you're going to have equalizing pressures. So your preload, all your preload pressures are going to be high because the heart is being squished. So everything is going to seemingly level out. So your right atrial pressure is going to rise. Your pulmonary artery occlusion pressure, that's the left side of the heart. Your pulmonary artery pressure, that's somewhat the middle. And as a consequence of all this being elevated, you're not going to have appropriate output. So your blood pressure is going to go down because of your cardiac output. And you would expect in cardiac tamponade your vascular resistance to rise. And so we're going to do a question. One of the review questions is going to talk about tamponade. And we'll see if you guys can pick it out with a lot of these equalizing pressures. So because we can't cover everything, and there's a lot to do with hemodynamics and hematology, just review, like I mentioned, the transfusion reactions and treatments. You probably only have to spend a half hour on it because you've done it a lot. Some other things they mention is idiopathic thrombocytopenia. That's ITP and plasmapheresis. They mention that very briefly in the review books. So just kind of knowing very vaguely what these are in case you happen to get a question. But I always say spend time equivalent to the likelihood of the content. So they're going to ask you the more likely questions on, agent reversals and those disseminated intravascular coagulation. They're going to ask you questions on HIT more likely than they would ask you something on ITP. Okay, and then spend a couple hours reviewing the cardiovascular agents that are going to change these parameters here. Okay, there's a lot there. There's maybe 12 different drugs that we could use in the ICU, and you'll see this a lot in the cardiac section too. That's what they really focus on, the cardiovascular section. So, spend 10, 15 minutes with each drug and just, how does it work? What does it do? And mostly what the CCRN wants you to know is, how does it change these values? Is it an inotrope? Is it going to raise our contractility and help with these stroke volume pressures and volumes, or is it going to decrease? Are we going to give drugs that decrease some of this preload? So just go through these one at a time and try to link it to this. Try to link it to why we're trying to correct these hemodynamic profiles. All right, so our first clinical question is, you get this following hemodynamic profile from your patient. This could very likely be a question on the exam. And you want to just go through these one at a time and try to remember, is this a preload? Is this normal? And then go to the next question. Is this a preload or afterload value? Is this normal? And I'll just remind that right atrial pressure is CVP. RAP is CVP. PA is pulmonary artery pressure. So they might abbreviate it just a little bit differently on the exam, so just keep an eye out for that. But go ahead, look at these, and we'll see what your conclusion is about these values. Okay, so we see that the blood pressure is stable, so we haven't gone quite into shock state. which it could just be a compensatory thing, right? We don't know the heart rate. So the heart rate might be high, compensating for that. We see our right atrial pressure, our CVP, is normal. Normal is 2 to 6. So that's 3. That's good. So that tells us that either we're in a state of euvolemia, we have good volume, or the heart hasn't backed up into the right side of the heart yet. Now, if we keep going, we see that we do have a high pulmonary artery pressure, right? That should be a little bit lower. And the same with the pulmonary artery pressure. So this says the left side of the heart is congested. This says it's backing up into the lungs. This says that the body is compensating. Stroke volume or systemic vascular resistance is compensating with a higher pressure. Actually, I should change that. That should be dynes per centimeter. Stroke volume index, right, and cardiac index, these are low. So normal stroke volume is 50 to 100. We know that we can get stroke volume index by cutting it in half. So 25 to 50, 25 to 45 should be a normal stroke volume index. So that's low. So it means we're not kicking out enough blood and our cardiac output is not compensating well. So we know that the heart rate must be fixing this blood pressure. And then we also notice that the SVO2 is very low. It's below 70. So we can assume that there's a problem with the left ventricle. Some sort of left ventricular failure is causing a backup. It's not pumping blood out correctly. The vascular system has to compensate with a higher pressure, like a higher back pressure. And because we don't have a good output, we have a lower SVO2. Because the blood that is escaping is being all used up. The oxygen that's escaping is being all used up. I'll let you look at the rationale real quick. It's kind of what I had just mentioned. And we'll go on to the next one. A patient with a continuous SVO2 monitoring system has a sustained value of about 50%. So what would a priority assessment be, and which one of these would it not be? We want to find one that's not a priority assessment. Now, I'll just mention that when we're talking about SVO2 being below 70, it needs to be sustained, right? Just like with any other value, if you see it change suddenly, you can't always trust that. You want to see sustained drops or sustained increases. So go ahead and pick one of these here. Okay. So we know that hyperthermia can cause an increased use of oxygen. We know a low SpO2 stat to begin with can cause a lower SVO2. And we know that a low cardiac output or blood pressure means less blood that's oxygenated is getting out, so therefore we're going to use more at a higher percentage. So urinary output doesn't necessarily mean we're going to have a lower SVO2. There's a lot of problems that can cause a low urine output. That doesn't necessarily mean we're not perfusing our tissues. Okay, so now we're getting a question that is asking us to predict, based off a certain hemodynamic profile, which we have to determine, what systemic vascular resistance would be. So we see a patient's come in 8 hours, status post-colectomy, and they have a low mean average pressure despite 1 liter of fluid. They have an elevated heart rate, elevated temperature, a low urine output. Their lungs are clear, warm and dry. They have a high white blood cell count and a positive blood culture. So you hook them up to a flow track, And what would you expect as a systemic vascular resistance? Feel free to pause it if you need more time, but what we're looking at is what we first need to determine is what kind of shock state is this? And if they've just had a surgery, they have positive blood cultures, white blood cell count, their temperature's up, they're not making much urine, we can assume it's an early septic shock because it's in an 8-hour period, potentially. And so, our guess would likely be having a lower systemic vascular resistance because of that early vascular permeability increase and without much congestion having built up yet. And you can tell that because their lungs are still clear. Your physical assessment, they're not diaphoretic and cold. So these little things that we often skip over can tell you a lot about the shock state, how early they are in a shock state. Now this next question, all that's changed is the time. So take notice to that. And now it's asking you, what would you expect as far as preload and afterload? Would they be increased or decreased? So with the late septic shock, right, we talked about this having still the same decreased preload. So you would expect to have a lower pulmonary artery, or right atrial pressure, or right atrial pressure being CVP. You'd expect that to be low. You expect to have a low pulmonary artery occlusion pressure because you're just down on volume. And you'd expect to have a higher afterload value, so a higher SVR or a higher pulmonary vascular resistance. Not necessarily that one because it hasn't backed up to the heart yet, but most certainly a high systemic vascular resistance. Not so much because of vascular tone, but because of that congestion squeezing the vessels, the edema. And I should change these. The lungs should be wet, and then the skin should be cool and damp. So that's my part. I'll fix this here, but these should be. You should also expect a change in the physical assessment. Okay, so this will be a little tougher because you have to remember values, but feel free to look at remember one or two, look back and remember one or two, but really try to challenge yourself and not look at the values if you can, the normal values if you can. I will give you a hint. One of these is right ventricular failure, and we'll go through which one that is. So let's just go through these together. And I'm not going to give the answers away, but I'll kind of guide you through thinking if you'd like. If not, then you can pause it and guess which one these would be. So this first one, you have all of these. You have a low blood pressure. Okay. And in 5, we recognize that already we have a compensatory tachycardia. All of these actually have that. And a low cardiac output. So we have a low cardiac output or index that matches our blood pressure. The body's trying to compensate for that somewhat. Our stroke volume's low. Notice this is stroke volume and not index. The test might do that to you. It might give you two different readings. So the stroke volume is supposed to be 50. It's not. So that could indicate potentially that the patient's hypovolemic. But we have to look at our right atrial pressure. Oh, our right atrial pressure is actually normal, right? 2 to 6. So maybe not necessarily. It might be something that's causing the heart not to be able to pump efficiently. And then we have an elevated pulmonary artery occlusion pressure. Right, this should be 8 to 12 with a high systemic vascular resistance. Okay, so kind of guess what that might be. We'll move on to the next one. So you've got a high vascular resistance, a high pulmonary artery pressure with a low stroke volume and index. Okay, this next one. Same deal. Low blood pressure, high heart rate, trying to compensate. But in this case, we have a high index. Right? With the elevated or somewhat normal stroke volume. This is actually normal, is stroke volume. But a problem we have here is, oh, wait, we still have a normal right atrial pressure. But our pulmonary artery occlusion pressure is low. It should be 8 to 12. So far we have a low pulmonary artery occlusion pressure with a high cardiac index and a low systemic vascular resistance. So you got to think, what would cause a low vascular resistance, low preload? Remember, this is low left ventricular preload, but still a somewhat high cardiac index. Okay. This next one, all of these are going to be the same. Low blood pressure, high heart rate. This is a low normal cardiac index. This is a low stroke volume. In this one, this is something different. High right atrial pressure. So we have a high preload on the right side of the heart, but a normal or low preload on the left side of the heart. So something in between is not right. Then we have slightly elevated systemic vascular resistance, so potentially trying to compensate with the heart rate for that low blood pressure. Okay, this one, again, low blood pressure, high heart rate, somewhat normal cardiac index, low stroke volume, right? For about half of what of the lower end of the stroke volume. Here we have a low right atrial pressure and a low pulmonary artery occlusion pressure. So low preload for both of these and a low stroke volume. And then just again, a slightly elevated systemic or vascular resistance, probably just compensating. Same deal here, but our heart rate's a little bit higher. Blood pressure's low, heart rate's a little bit higher. Cardiac index is low. Stroke volume is low. Look at this. Our right atrial pressure is high. Our pulmonary artery occlusion pressure is high. 8 to 12, that's a lot higher. And our systemic vascular resistance is somewhat normal. So go ahead and try to collect your answers about what you think these might be. This is probably going to be one of the hardest parts of the test, is thinking about what would cause these problems, what would cause these numbers to be raised. And we'll go through them here in a second. All right. So we'll go through, I highlighted the numbers just so we can see easier what kind of triggers you to think about these different things. So 5, we'll think about this first. So we got a low cardiac index with a high pulmonary occlusion pressure. So there's backing up. and a high systemic vascular resistance. That means the systemic vascular resistance is still able to compensate for the cardiac index. So it must mean something's going on with the left side of our heart to cause this backup and low output. So we're backing up here because our heart can't pump properly, which gives us a low cardiac index. And the body's trying to compensate by having a higher vascular resistance because the body's still able to do that. That's not broken. But when you come over here to septic shock, this must be early septic shock, right? Because of this low systemic vascular resistance. We see that despite the low blood pressure, the body can't respond. All of our preloads are low, which would make sense in a septic shock. But our cardiac index may still be able to compensate at this point, because we still have a somewhat normal functioning heart. The heart can still become tachycardic, can still fill with blood. But as this worsens, as we get less volume and the stroke volume goes down, this cardiac index is going to go away. So this is definitely a tricky one. And this one wasn't stuff we really talked about, but the high right-sided heart pressure makes you think. With a high right-sided pressure and a low left-sided pressure, it means that something in the right ventricle and the right side of the heart isn't allowing blood to get to the left side of the heart. That's why this is high and this is low. And then the cardiac index shows that it's low normal. So the left side of the heart must still be trying to work well. It's just the right side is giving us trouble. Number 2 is more of a hypovolemic shock. It looks very similar to septic shock because of these low preload values, right? Low right-sided preload, low left-sided preload. The body's just barely able to compensate, or it's not able to compensate. It's trying to with this heart rate, but the blood pressure is still low. And then finally, this one isn't necessarily a shock, a type of shock, but it's cardiac tamponade. And you can see that because you have high pressures on both the right and left side of the heart, right? In cardiac failure, you don't have that because the left side of the heart is bad. In right-sided heart failure, you don't have that because the left side of the heart may still be functioning properly. But in tamponade, you have high values on both sides because the heart is being squished. And if you're in between tamponade and something else, you can look at heart rate and think, oh, tamponade hurts, right? So my heart rate is going to be a lot higher because of tamponade, because it hurts. So if you had a pulmonary artery pressure value in here as well, you would expect that to be high as well. So they're not going to give you 5 values. They're not going to give you 5 different profiles like this, but they may give you 5 profiles throughout the exam. And that's kind of how you have to pick through and recognize what's linking up and what's making sense. You got to just either circle in with your mind, okay, that is different from that. That's telling me that my right side of my heart has a higher pressure, but my left side isn't, so something must be going on between. I'm going to say that's right-sided failure. And so that's going to be how you have to go through these. And the best way to do this is just practice. Practice and read the rationale of why these values are leading the person to say that specific shock state. So just practice. And that's the end. That's the end of the day 2 presentation. Hemodynamics is definitely a something to practice a lot with because it'll be merged with cardiovascular. So just go through these, practice them, and once you get your test book or your practice tests, just really put some extra time into hemodynamics once you start taking those full length tests. So thanks for being here with me again, and yeah, feel free to rewatch this video, share it with somebody else who's taking the test or going to take the test, and let me know if I missed anything. Bye.